kind enough to bring us Dr. Milligan here from Equine Specialty Hospital. She's going to talk to you today a little bit about colic. Colic surgery is one of her specialties, correct?
Yes.
Correct, all that information. So please enjoy and thank this vet for coming and sharing her wonderful information with us.
Thanks.
Thank you. If you guys have questions throughout the talk, don't hesitate to stop and ask me. If I can't be heard, also speak up and let me know that you're having a hard time hearing me, and I'll either repeat or talk louder or things like that. So don't be afraid to be very interactive throughout the whole presentation. We're going to talk initially a little bit about the basic colic exam first, and then proceed into the different types of colic, treatment options for them, and a little bit of prevention as well. There's a lot of misconceptions about colic and things like that. Part of that we're going to go over with an anatomy review to help you understand why there's all of these misconceptions. That'll also help you figure out what colic is and how we diagnose it and how our diagnostic tests relate to the anatomy that we're dealing with, as well as treating it and then prognosis. There's a lot of myths out there for colics, but the number one fact is that it does kill horses. It's the number one cause of death in horses worldwide, but it's also treatable in a lot of cases and manageable and in some cases even preventable. The good news is very, very few horses actually require colic surgery. In our hospital, we're a referral hospital where we see the worst of everything, so a higher percentage of the horses that we see need colic surgery because everything is so severe when it comes to see us. But on the farm, very few of the horses that actually colic require anything more than Banamine and some laxatives and some supportive care. That being said, every colic should be treated as an emergency because some colics can start out very, very minor and escalate very quickly. And if you can get a diagnosis early in the course of the disease and the problem, your prognosis is much better. And oftentimes if you start early, it can even be cheaper too in the long run if you can start treatment early and prevent it from escalating to a much higher problem. Just by definition, a lot of people don't understand really what colic is. Colic just means abdominal pain for any number of reasons. They don't necessarily get colic. It's more they are colicking type of use for the verb. And they can have abdominal pain from anything from gastric ulcers to, they can have a bladder stone. That's a pretty common thing that people think, oh, he's straining to urinate, so he has a bladder stone. They can. It's pretty rare. All the way to the classic twisted bowel and dead intestine and things like that. It's a huge spectrum of things that they can have wrong in there. Probably the number one thing that we hear that's the most common misconception is that the horse rolled, caused a twisted gut, and now it needs to go to surgery. That's actually the other way around. They are rolling either to scratch because they've got new bedding or they itch or they're just rolling to be a horse, or they are rolling because there's already a problem in the abdomen, such as a twisted intestine or something like that, and they are trying to find a comfortable position in which to lay. So they will not make the abdominal problem worse by rolling, okay? The reason we tell you do not let them roll is they can traumatize their head and their legs severely by rolling during a colic episode. We don't want them to scratch around their eyes or their ears or damage their eyeballs, things like that. We don't want them to lay down and roll and kick through a wall, things like that. So that's the reason we ask you to keep them moving, keep them up, and keep them walking, just more to protect them from themselves. Other people, it's common, people come in and they'll have anything from an 18-year-old horse on up to late 20s, and they say, oh, he's too old to survive colic surgery. That's not the case. They very easily can survive colic surgery. You start getting into the 20-year-old horses, you have some arthritis and things like that might affect their ability to stand up after colic surgery. But as long as they are overall healthy, they have the same ability to survive colic surgery and a colic episode as a younger horse. You just have to be aware of some things you might have to watch for, difficulty standing up after anesthesia or something like that. Once they survive colic surgery and come through it, and most of our prognosis rates are actually about 80% after surgery, they can return to their normal level of competition. Whatever they were doing before once they heal and get the abdominal incision healed up, they can go back and have the same job they had before, at the same level of competition. They just have to get back into physical shape because they're off for several months to heal, but they can, return to doing what they normally do.
Is that hold true for geriatric horses as well?
The question was, can older horses also go back to the same level of competition and activity and be ridden again? And that is true, yes. If they were rightably sound before colic surgery and they do well through the colic surgery and they heal, there's no reason they cannot go back to the same level of riding activity, and that's somewhat unrelated to age. Yep. Another common misconception is that once a horse has colic surgery, they will always become a problem for you. And in some instances that is true. In other instances it is not. And we can usually tell you which cases are going to be problematic in the future based on our initial exam and knowing exactly what's wrong with them and why they need colic surgery. For example, a horse that goes to surgery for a small intestinal problem does have a little bit higher risk of chronic colic problems in the future versus one that has a large intestinal problem. And we're going to be able to determine which of those two categories the horse falls into before we even take it to surgery. And so you can use that knowledge and we can help you make a decision that's right for you, your family, and your horse as far as whether or not surgery is something that you want to proceed with. Sometimes this next one is true. If the horse passes manure, that's always a good thing. It doesn't always mean the horse is fixed. If the problem is at the front of the intestinal tract, they still have all of the manure behind it to pass out. So they can still pass manure and still have an ongoing problem in there. It just depends on where the problem is located. But we always want to know how many times has the horse passed manure since it started a colic. Is that manure normal consistency? Is it liquid? Is it too hard, too dry? Those are all important things for us to know, but we have to take it with a grain of salt. Have they passed manure and it's fixed? Sometimes that's true, but not always. This is also another one. If you give the horse Banamine, which you should, or your vet should do when they're colicking, Banamine is a good thing, that's not going to mask a surgical problem. You're not going to cover it up. You're not going to be delaying treatment. If it's a surgical problem, it's going to be severe enough that Banamine won't mask it. It will show through that medication. So it's important that that horse get a pain reliever and an anti-inflammatory as long as we know when they got it and how much they got. We can always use that information to help us determine what's needed. We talked about this just a little bit ago. If a horse is stretching out to urinate but not producing anything, it's possible that they have an obstruction in the bladder or the urethra from a stone, but it's extremely rare. Horses with that problem have bloody urine. They urinate in small spurts, but they can urinate. Horses that are just stretching out to urinate like this, they're trying to find someplace comfortable. They're trying to do something to make themselves, less stressed. And if something is pushing on the bladder, if the intestines are pushing on the bladder, it will stimulate an effective. They feel like they should urinate, so they try, but there's just nothing there left to come out. So it's an important sign of colic and abdominal pain, but we need to make sure we don't misinterpret that clinical sign. The anatomy of a horse is probably one of the most frustrating things to deal with because they're put together really, really badly. We have a saying that God made horses last and put them together with bits and pieces left over from everybody else. There's 60 feet of small intestine, there's 10 to 12 feet of large intestine, and everything's only attached in one spot. So it can move around a lot more than your intestines as people, your dog's intestine, cats. They're all attached down, and so they don't have the ability to have issues like horses do. On the left side, we can see large colon here on the left. Small intestine can meander wherever it wants to go in the abdomen. We've got stomach on the left as well here. And then small colon, going back into rectum, that's all just on the left. The attachments, are just in one place, so it can move wherever it wishes to. On the right side, we also have large intestine, and the picture is a little bit different color, but it looks pretty much the same. We can't tell the difference on ultrasound between left and right side because it's identical as far as structure goes. Again, there's small intestine there. Cecum is on the right side as well, and it's all packed into one very small space, and as long as it stays where it's supposed to be, everything is fine. But because of the fermentation that they have from eating grass and things like that and hay, they get a lot of gas buildup, and that can get caught, cause them to gas colic, can lead to some other issues as well. Sometimes we take a horse to surgery and we find that we cannot fix the problem because we cannot get to the area that's an issue. Of the entire abdomen, we can only treat surgically about 75% of it. Can't do anything about the stomach. We can feel it, but you cannot see it at the time of surgery. We can't do anything about the first 3 to 4 feet of the small intestine or the base of the large colon, large cecum, things like that. Spleen, kidneys, liver, we can feel all of those things, but we can't see any of them. So if it's a problem with those particular organs, the chances of us being able to fix it isn't very good. And sometimes we don't know that until we actually open the horse up and truly explore the abdomen and identify what it is. That still, though, leaves a pretty good portion of the abdomen that we can do something about. Those of you that have horses, how many here have had a horse colic and have had to deal with that? Okay, so a good portion of you. You've seen the rolling and the pawing. This horse, self-traumatized, he's all banged up around his eyes. Give him 24 hours and he's going to look like he lost a boxing match. His eyes are going to swell shut. If we can keep him from rolling, that's going to be avoided. They may strain to defecate and urinate. They're going to look at their abdomen. Or it may just be as mild as they just didn't eat their breakfast that morning. It can be a huge range of clinical signs, and depending on how well you know your horse, how tough your horse is versus the really stoic ones versus the ones that can't handle a lot of pain, we need to know the temperament of your horse as well to help determine the severity of what's going on. When you find your horse colicking, there's a lot of things that you can do on the farm that will help your vet determine how quickly they need to get to you, or if you should just drop everything, load the horse, and take it to a referral center because it's faster and more efficient to do, just skip the middleman. Everybody should know how to take the heart rate of a horse, respiratory rate, and temperature, and have that information available when you call your vet. Easiest place to listen for a heart rate is going to be right behind the left elbow. Stick your stethoscope way up behind there, and you can hear it at that point. We all just use digital thermometers from Walmart for temperature, and it's important to know if your horse has a fever or not, because some types of colic, such as diarrhea, aren't surgical, but they can be very, very painful. And if they have a fever of 104, that helps us determine, okay, is this going to be more of a diarrhea type situation or what's going on? So we need to know if the horse has a fever. Normal should be somewhere between 28 and 48. And if you go out and take your horse's heart rate every day for a week, you're going to know what your horse's normal is. Some horses are going to be 30, others are going to be 48. You just need to, everyone's different. You just need to know for your horse's sake what's normal. Because if your horse's normal is 30 and you come out and one day he's rolling a little bit and pawing and his heart rate's 48, that's abnormal for that horse. And so it's important for your vet to know that as well. Respiratory rate, not quite as critical as heart rate when we're trying to determine severity of things. And then temperature for sure, 101.1, 101.5, somewhere in there or less is normal for an adult. All right, babies are different. Babies can have up to 103 and be perfectly normal. Their temperature range is different. But for an adult horse, anything 101 or less. It's also important if you can listen to intestinal sounds. You're going to listen in right and left flank, both sides, and you're going to hear gurgling. Might sound like a coffee percolator or water running, waterfall, anything like that. If you hear nothing, that's never good. That's going to be worse than hearing too many gut sounds. And so getting an idea of what your horse normally sounds like is a good idea. Being able to tell your veterinarian that your horse's heart rate is 60 with a fever and no gut sounds, that gives him or her a really good idea of what might be going on and where to start looking. You should also know where your vet's number is. If you have a boarding facility, the vet's number should be posted. If you've got more than one veterinarian that services that barn, each horse, and some people have a preference, you have everybody's information posted where they can find it, know where the closest surgical referral facility is, and know how to get there. The worst thing you need to do at 3 in the morning is say, oh no, my horse is colicking really bad and he has to go somewhere, but I have no idea where to take him. I don't know how to get there, and I don't know how long it's going to be. If you have at least an idea of where you're going to be headed already, it streamlines things. The other thing to make sure you know is, does your horse load on a trailer? Do you have a trailer? Do you have a way to get your horse to a surgical facility if it's needed? If it's at 3 in the morning and your horse is really critically ill, waiting 2 hours for a trailer sometimes can literally be the difference between us being able to save the horse or not. So knowing how you're going to transport your horse to a surgical facility, where that facility is, and making sure your horse will get on a trailer in a timely fashion is a whole lot easier to get everything lined out and worked out in the middle of the day than waiting for the middle of the night in an emergency. Before your vet gets there, need to make sure that you keep them moving. We don't want them to hurt themselves, and we want to make sure that they don't eat or drink anything. Until we know for sure that they can pass manure out, nothing else needs to get added to the system. And that's even if they start feeling a little bit better. Do not let them eat anything until your vet gives the okay. Everybody loves, yes?
When my guy, my building, he looks colicky and he won't eat his breakfast. The first thing I do is I take him out and I see if he wants to eat grass. Because if he wants to eat grass, I know he's okay.
Sure.
Bad. And I also think that grass has moisture in it, which is going to help.
Yeah, the question is, she has a horse that sometimes has a little bit of a particular appetite. Sometimes he doesn't always want to eat his breakfast quite so well. And she kind of checks it with a couple bites of grass, and if he is eating the grass well, it does have a high moisture content too, which is always good. It helps her determine if he just is having, kind of picky and not doing so well, or if he truly is sick. And that's not necessarily a wrong thing to do. You just wouldn't want to let him eat a lot of grass. So it's not.
It's kind of like when I go to look this up and he's still like that, I'm like, okay, you're fine.
Right.
And
And this is another instance. She knows her horse very, very well. If he's not going to eat a bunch of grass that morning, you know that he's ill, and you're going to proceed with getting veterinary care. Yep. We talked a little bit about giving Banamine, and Banamine is good. It has anti-inflammatory properties. It can bring down a fever, all of those things, but we need to administer it safely. Okay. Everybody wants to have that emergency dose of Banamine sitting on the shelf in the barn. There's a couple things wrong with that. That can be dangerous. First, the needle can fall off at any time. Somebody sticks it back on. You've still contaminated the syringe. The plastic, if you've got the medication, the plastic in the syringe can interact with the medication. It can deteriorate. And so when you give it, it's not safe to give anymore. If it's drawn up and sits there, any little bit of bacteria that was accidentally on the needle when they drew it up, can contaminate it. So you have to be very, very careful, with that syringe of Banamine.
I have a question.
Okay.
If you don't have Banamine on hand, can you use Bute?
Question is, if you don't have Banamine on hand, can you use Bute? Technically, the answer is yes. They're both in the same class of drug. It may not work quite as effectively on abdominal pain as it would musculoskeletal things, but certainly it will have a little bit of an effect. Keep in mind that anything you give orally will take anywhere from 45 minutes to an hour and a half to work. So just be aware of that. There are some, and then Bute, does have to be given orally. An intramuscular injection of Bute is disastrous. If an intravenous injection of Bute gone wrong can be very, very harmful as well. So if you've got Bute, it's probably the oral kind. It'll just take a while to work, just as Banamine would. That being said, we need to be careful. This is what happens when an intramuscular dose of Banamine goes wrong. Okay, they get a very bad infection that requires huge surgical incisions to drain the infection out of there. It can scar, and it can be fatal. So if used correctly and safely, given either intravenously with a skilled person administering it, or in the mouth, you can squirt liquid Banamine in the mouth, and it's not going to cause any problems at all. It's much safer than giving an intramuscular injection of Banamine, so that's something that we do not recommend. checking, heart rate, respiratory, we talked about the GI sounds. The next part of the exam is looking at their mucous membranes. They should be a nice, healthy, shiny pink. Make sure that you know if your horse has pigmented membranes or not. Some horses have black spots on their membranes, and that's normal. I got a call one time at midnight saying, my horse's membranes have turned black overnight. They'd never looked at their horse's membranes before, and they were normal color. Horse was perfectly fine. It's just as pigmented, and they had never noticed that before. So just make sure you know what your horse looks like. You should always have an ability, if you put your finger right next to the tooth and push it there real hard and then pull it back, that little white spot should go away in less than 2 seconds. All right, if it doesn't, it means they're dehydrated. When the horse is evaluated by a veterinarian, either on the farm or in our hospital, they're going to have a rectal exam. Even if they've had one done on the farm, we're going to repeat it. Things can change very quickly in transport. Even within an hour, things can change. And so we need to know exactly what we feel compared to what your farm vet felt. And we're going to sedate the horse. We may even put a twitch on the horse just for your horse's safety and for ours as well, because we don't want to create a rectal tear or anything like that.
I had a case of colic. My mare had the farm manager called me about 2 hours when it first started. She refused to call the vet. And I told her several times to call the vet, it's very bad. Now, the vet couldn't even get their arm up the rectum to do the thing. They said everything had twisted inside.
Right.
If they had acted sooner, would there have been a possibility it could have saved her life?
The question was, it took a while for the vet to get there to evaluate the horse, and by the time the vet got there, the abdomen was so distended that they couldn't even insert their arm to do a rectal exam. The sooner you find it, certainly, and refer to a surgical facility. We have saved horses that are that distended. We take them immediately to surgery, and we are able to put things back in the right place and remove the gas and save them. So it just depends on the physical status of the horse in addition to the rectal exam findings. When we are feeling per rectum, we're looking for any intestine that's thickened. We're looking for anything that is too big. And we're feeling for what we call tight bands, which is a natural part of the large intestine that you can only feel when it's full of gas. As you can see over there on the right, this is really big around compared to normal size, and we can tell the difference, and we can make diagnoses based on size of intestine and how thick it is and things like that. If the horse is just mildly uncomfortable, we may repeat that rectal exam 12 hours later and compare and see how the horse is doing and make that determination. If it's getting better, we just keep going with our medical treatment. If it's getting worse and the horse has failed to get more comfortable, we're going to recommend surgery maybe at a later date, not necessarily immediately on admission. Because horses can't throw up, we're going to pass a tube every time we're worried about an overly full stomach. If we don't pass a tube and that stomach is too full, that stomach is going to burst, and that is fatal. And so a lot of times passing a tube, will save lives if we can get all of that extra fluid and food out of that stomach. If there's extra fluid in the stomach, it's because there's either a physical obstruction, like somebody stepping on a hose and nothing can get past, or there's so much inflammation and irritation in the intestine that it just physically can't move. And our diagnostics will help determine the difference between that. If there is extra fluid in the stomach and we know that things are not moving through, we do not give oil, period, because it's just, if something can't move through, we're not going to put more in and add to the problem. Not necessarily on the farm will every veterinarian be able to do an ultrasound because they may not have the equipment, but when it comes into the hospital, every horse that comes in for colic for us is going to get an ultrasound. We can't reach everything on rectal. We can only reach in so far, and this gives us a much better idea what's going on in the front of the abdomen and on the bottom of the abdomen where we can't feel very much. We can tell if there is distended intestine. We can tell if there's any fluid there, or any of the other spleen involvement, kidney involvement, liver involvement. We can tell all of that. And it helps us determine how thick the body wall is for our, one of the other diagnostic tests that we're going to be doing here in a little bit. It's very non-invasive, it's non-painful for the horse, and it's a pretty rapid test to give you an idea of what's going on. With the ultrasound though, we can't tell the difference between any of the segments of the small intestine. Of that 60 feet, they all look the same. Same goes for the large colon. There's a dorsal or top portion and a ventral or bottom portion, and they all look identical on ultrasound. So we have some limitations there. We can also only see in 8 to 10 inches. So if you have a big horse and you only see in 8 to 10 inches on the side and up from the bottom, that still does leave a good portion of the abdomen that we may not be able to evaluate thoroughly, but it's a whole lot better than just a rectal exam. The final test that we're going to do is put a very small needle through the skin of the bottom of the abdomen. We're going to clip that area, sterilely prepare it to make sure we don't introduce any bacteria, and we're going to sample the fluid that's bathing and coating the outside of the intestine. Clear pale yellow fluid here is perfectly normal, progressing to red, cloudy, and bloody on the far right. If we're seeing that red, cloudy fluid, that means that there's something surgically wrong in the abdomen and the horse needs to go to immediate surgery to remove typically what ends up being dead intestine that's lost its blood supply. And we'll get to some examples here in a bit. If necessary, we're going to check blood work for hydration. You check white blood cell count to make sure there's not an infection there. We're going to look at urine, like BUN and urinary system, liver, all of that to make sure that they're functioning normally. Check and make sure their electrolytes are okay. This is especially important in horses that haven't been eating for a while. Blood gas with lactate. The lactate will tell us pretty much how distressed the horse is. The horses that are surgical, and you're trying to decide if they're able to be saved or not, it's an excellent indicator of prognosis. A lactate of 1 is normal. We get horses with lactates of 6, 7, 8, greater than 10. Those horses, we'll do everything we can to try and save them, but oftentimes it means they're so sick that we may not be able to, but we will do everything we can to try. X-rays, in people, if you have abdominal pain, you're going to go to the emergency room and you may get an abdominal X-ray or a CAT scan, either one. In horses, that's not usually feasible because they're so big on adults that you can't get X-ray penetration through there. Not the same though on babies or miniatures. They're little enough that you can see through them. So, those are the ones that we're going to be X-raying if we can't get the information we need from an ultrasound. A fecal flotation, I know there's a stand out here in front that was offering fecals today. That's something that we'll do at a later date. It's not an immediate necessity upon arrival, but it's good to know if there may be some inflammation and irritation of the lining of the intestine due to parasites and things like that. We're also, not so much here in Ohio, but southern states, sand is a huge deal. And so if you take a normal sized pile of manure, put it in a rectal sleeve, put a bunch of water in it and let it sit and dissolve, you get any little grains of sand down in the tips of the fingers, you've got a sand issue. And then you're going to be looking at sand clear and anything you can do with those commercial products to try and get it out of there because they can impact. But if you feed on mats, if you have to feed, in a sandy lot or something like that, make sure you're feeding up off the ground or in a big round feed tub, something to make sure they're not ingesting any sand. It's a pretty easy cause to prevent. Ulcers is a very common cause of colic, and they can be secondary to other problems, or they can at least make other problems worse. It's almost always the next day because the horse has to be fasted before we can get a really good image of the stomach. It takes about 18 hours for them to completely empty to make sure that we get an adequate visualization of everything. And then 4 hours before we take the water away, and they can be fine for that period of time without food and water. There's 2 portions to the stomach. There's the light pink portion at the top, and there's nothing produced in this area. There's no gastric acid produced there or anything else. Then there's the junction between the 2 portions, and that's called the margo plicatus, and that's a typical site for ulcers. And then there's the glandular portion, which is the dark pink portion way at the bottom, and that's where all the gastric acid is produced. And we want to be able to see all 3 portions like that, and without fasting, that's usually not possible. So now that we've got our exam done, we need to use all the information that we've gotten to determine if it's a medical or a surgical problem. Surgical colics are very painful. We cannot control their pain with medication. They have a lot of abnormalities on rectal exam, passage of that nasogastric tube, and ultrasound. And they deteriorate consistently over time. They're not stabilizing, they're not responding to treatment. So that's how we determine if it's a medical or surgical colic. If the horse is just standing there and watching us and not horribly uncomfortable, might have a little bit of gas in his colon, that horse is going to get treated medically until he either gets better or he continues or gets worse. But we never take a horse to surgery just because. We are always going to have our diagnostic results telling us that it's necessary. Fortunately, though, most don't need to go to surgery. They can be treated medically. We're going to rehydrate them with IV fluids. We're going to manage their pain with judicious amounts of Banamine, maybe the very occasional dose of sedation. Some horses that have impactions are going to get a laxative. Others that have an infection are going to get antibiotics. And then, those horses that have ulcers, we're going to treat the ulcers. We're also going to give preventative medications to those horses that don't have ulcers to make sure they don't get them while they're in the hospital. If all of these things fail, then these horses can become surgical candidates. And within that surgical umbrella, there are two separate categories. One is no damage to the blood supply. The other is a damaged blood supply that requires removal of that intestine, okay? And sometimes we know that prior to surgery, other times we don't. The horses that have obstructions without any damage to the blood supply are typically less painful. They're not standing still. They're still trying to lay down and roll and paw, but they're not thrashing violently and trying to hurt themselves. These are typically your large colon displacements, where it's strictly moved into a wrong location, but it's not actually twisted, okay? Or it could be an enterolith, and what an enterolith is just basically a stone that forms in the intestine, almost like a pearl in an ocean. And in a pearl, in an oyster that, either freshwater or ocean, you've seen how they form around a grain of sand. Enteroliths are the same, and they act like a cork in a bottle. As soon as you take the cork out, everything's fine, but surgically you have to go in and remove that enterolith. The other category is the strangulating kind, where you actually lose blood supply to the intestine. These are severely painful. These are the horses that may also have renal abnormalities and electrolyte imbalances. These are going to be your large colon torsions, which is your classic twisted gut, which probably was your mare, we'll talk about afterwards. And then the small intestinal lipoma. And we'll discuss each of those a little more discreetly, but you've got nice pink healthy intestine, you've got not so pretty looking ones, and then this is just black. And once it turns purple and black, there's no treatment for it except to actually remove that intestine and reconnect the healthy ends. Afterwards, they come out of surgery, they get moved back to their stall after recovery. They're going to get IV fluids. They're going to get antibiotics and pain management, anti-ulcer medications to prevent ulcers at this point. And we're going to very slowly reintroduce food and water. And we are never, only horse people, veterinarians and otherwise, are very glad when they start passing manure. And we document that very, very closely. That's something that we watch every 2 hours, and we're literally counting how many piles they pass. And that helps us know when to start feeding them again. Once a horse has colic surgery and they're sent home, there's no change in the bedding. You can use straw, shavings, sawdust, whatever you like. We typically do not have to change their diet. They don't need any alterations to that. And the remainder of it is typically what's needed to let the body wall heal. There's an incision about that long in the abdomen, starting at the umbilicus and going forward. And that has to heal to enough strength to support everything. And so they're in a stall with hand walking for 30 days, then a small paddock or round pen by themselves, and then the last 30 days they're out doing whatever they please, but you're not forcing them to do anything. And typically 90 days from the day of surgery, they are back to work doing whatever it is that you want them to do. Unless the horse is nasty enough to kick someone severely, we're going to close that skin incision with staples. And those have to come out at 14 days after surgery. And that's the fastest way to get that skin closed. And the faster we are at surgery, the less time they spend under anesthesia, all the better. That said, if the horse is trying to hurt us during our colic exam as we're working on the bottom of the abdomen and things like that, your horse may get closed with absorbable suture, so nobody has to stick their head under the abdomen to take them out. So 99% of the time it's staples, but from a safety perspective, sometimes we do use absorbable suture. I wanted to switch gears just a little bit and talk a little bit more specifically about the most common things that we see at Equine Specialty. Medically, probably the #1 cause of colic that we'll see that does not require surgery is ulcers. They can anywhere from mild to moderate signs of pain depending on the horse's level of tolerance. All of our other findings on our colic exam are normal. We're not finding anything on rectal exam. The ultrasound's fine. The fluid in the abdomen is okay. All of our blood work is all right. They may or may not have had colic histories in the past. Some horses have raging ulcers and only colicked the one time. Others have very small ulcers and are kind of repeat offenders. It just depends. And there's 4 grades that we find. Top picture there on the right just shows a teeny tiny little ulcer. That's a grade 1 versus the bleeding ulcer on the bottom, which is a grade 4. And it can be any range in between. Treatment for it, there is only one FDA-approved drug for treating ulcers, and that is Gastro Guard. The reason it is so expensive is because it's treatment to allow it to be absorbed into the body and actually function. The generics do not have that enteric coating, so it breaks down and it's not absorbed. They just don't benefit from it. It prevents acid production versus some of the other medications that act as a gastroprotectant. That's what sucralfate does. It turns into a gel and binds to the ulcers and actually coats them and protects them. Your Zantac, your Tagamet, that prevents acid secretion. So a lot of times we'll use these all in combination until we get the horse stabilized and then continue treatment with Gastro Guard. Ulcer Guard is an over-the-counter medication that prevents ulcers but doesn't heal them because the dose that you give that is only a quarter of your treatment dose, and so it will prevent the formation of ulcers, but it won't do anything to treat them once they have them. Other things you can do to treat gastric ulcers would be to alter their diet. We want to make sure that they have constant access to something in their stomach. The more food that's in their stomach, the less contact the gastric acid has with the lining of the stomach. Alfalfa is always good, helps those ulcers to heal. We need to minimize the sweet feed. That does stimulate acid production, so we're looking more for a pelleted type diet in these horses, and we'll increase the fat content of their diet. Horses that do seem to like oats, they seem to handle that pretty well, and they're not harmful, so if they're already on that type of diet, we generally leave them on it. Anterior Neuritis is going to be our second most common medical small intestinal problem. It is an inflammation of the small intestine, almost like the stomach flu in us. Causes them to have a lot of extra fluid and reflux in their stomach, causes them to be mildly to moderately uncomfortable, and oftentimes they'll have a fever. And this is where your physical exam at home is helpful, especially if you're going to give Banamine. If your horse has a fever before you give Banamine, we need to know that, because if your vet comes out and evaluates the horse after you've already given Banamine and it has a normal temperature, is that because it had a normal temperature to begin with, or did the Banamine suppress it? So making sure we know what the temperature is important. They will have normal fluid surrounding the intestine when we sample that for enteritis, and that's very important as we differentiate between enteritis versus something surgical. Most common cause is a bacterium that is in the environment. It's called Clostridium difficile. There's a good treatment for it with metronidazole or Flagyl is the medication. Can it be contagious? Yes. Can people get it? Yes. Speaking from personal experience, you can get it, you don't want it. So these horses we don't necessarily isolate, but we're very careful to wash our hands and things like that. Only about 10% of these cases will require surgery, and the prognosis for these is really, really good. Out on the farm, the most common cause of colic that you'll see probably is what's called a gas colic or gas tympany. They're a little bloated, mildly uncomfortable, and you give them a dose of Banamine and some oil, and things settle down. You walk them around for a little while, and they pass gas, and life is good. That's very typical, and honestly, that's probably the best thing you can hope for in a colic, is just to respond that quickly. Large colon impactions or constipation is also pretty common, especially in the wintertime when they're not drinking enough. They're mildly uncomfortable, respond well to a dose of Banamine. They probably are not going to have normal manure production. They may have the number of piles that are correct, but if you look at that individual pile of manure, each fecal ball is going to be too small, too dry, and too hard. And that's an indication that they're potentially working on an impaction. It's a very distinct rectal exam feel. It's usually on the left side, and that manure is so hard you can't even indent it with your finger. It's harder than like too hard bread dough. It's really hard, and the rectal exam is diagnostic here. And we do not take these horses to surgery. It's impossible because you can't. The colon is stiff, and you can't bend it to get it out of the abdomen. There's really not a surgical treatment for them. So they're given laxatives, IV fluids, and they respond really well. The large colon displacements we briefly touched on before. They can be mildly uncomfortable to hardly even noticing it versus pretty severely down and rolling and things like that. On rectal exam, we feel a lot of gas in the colon, and most of the time we can resolve these medically. We don't need to take these to surgery. But if they don't respond or they're so uncomfortable that they cannot safely receive their IV fluids, that's how we make the determination that they need to go to surgery. This is going to be normal here on the left side. Spleen and colon is here. What can happen is that colon can get stuck up here above the spleen. That's pretty easy to resolve. Or, as you're looking from the back of the horse, the colon is over here on the right instead of on the left. Combination can happen as well, and all because that colon is only attached over here on the right side. It can do whatever it wants to do. And we take them to surgery, put the colon back in the right spot, and in 85 to 90% of the horses it stays there permanently, and we don't have to have a chronic colic discussion. The colon torsion is your pretty classic severe twisted bowel horse. These are the horses that are so painful that you cannot keep them standing no matter what you do. These are the horses that get their heads beat up, their legs beat up, they're bloated like a tick. They're just violently uncomfortable. Most commonly seen in mares 6 months after foaling, up anytime, day 1 after foaling up to 6 months. And it depends on how quick you get them to a surgical facility and how quickly you get them to surgery, what the prognosis is. If they've been twisted long enough to cut off the blood supply, prognosis is going to be around 50%. But if you get them there really quick, get them untwisted, and they haven't damaged the blood supply, 85 to 90% of those horses are going to do fine. It all depends on time. And so the sooner you can get a vet out, and if you can't get a vet out, load the horse up, bring it into the hospital. Time really is of the essence in these cases. You can see here how that's dead and that's alive. There's a very distinct line of demarcation between dead tissue and live tissue in these cases. And depending on where that line of demarcation is, we may or may not be able to remove it. A lot of times it's so far down in the abdomen that I can only feel that line. I can't see it. And so if that's the case, we're not going to be able to save that particular horse. So that's why if we can get them to surgery very quickly, we can prevent that from happening. Yes, ma'am.
What's the significance of this? Is it just the change in size in room in the abdomen?
Oh, after foaling?
And I guess second part of that would be, is there any help by ones that are bred back?
Sure. Question is, why is it so common in mares post-foaling? And the theory is because there's all of a sudden this extra room in the abdomen. I could buy that up until about the first week, but why they tores at 6 months, that doesn't really make any sense. So we don't really know the answer to that question as a profession, okay? The second part of her question was, if you breed them back really quickly, does that help prevent it? And unfortunately, it does not. So. We were talking a little bit about enteroliths before. These are the stones that actually form inside the abdomen. I've taken out probably 1 a year since I've been here in Ohio, since 2007. But they're a lot more common in Florida, California, Texas, places with a lot of sand. Half of them that I have found have been what we call clinically silent, meaning I took the horse to colic surgery for another reason and found it while I was there and removed it to prevent it from causing a problem later. I've taken out something as small as this. The biggest one I have is about that big and weighs 5 pounds. It just depends on each individual horse. They can have one or they can have more. The most I have taken out is 4 at a time. If they're round and smooth, there's only one. If you take out one with a flat side, there's another one in there somewhere, because the only way they get flat is to have those stones rubbing together. So these, they're very hard to find preoperatively. You cannot feel them on rectal. You cannot see them on ultrasound. All you have is a horse that has a lot of gas in his colon, and he's getting very, very bloated very rapidly, and he's very painful, and you take him to surgery, and then you find it at that time. And they're a lot of fun, actually, because this is the only reason I can actually give back to an owner why their horse went to colic surgery. It's the only time you'll ever get a souvenir. And so many times you have a very expensive bill, colic surgery and things like that, and nothing physical to show for it except for an interlith. I can actually take it out and say, this is why your horse needed to go to colic surgery. This is why you're having to spend the money, but your prognosis is also really good. So they're a little bit more fun sometimes than some of the other surgeries. Diarrhea, though, not so fun. They can be extremely painful from it, just like you and I that have really bad diarrhea sometimes. We're colicky. We're wanting to curl up on the couch and our abdomen hurts, and there are times when we end up in the hospital for it. They can lose a huge amount of fluids very, very rapidly, foals in particular. So anytime your horse develops watery diarrhea, that is a true emergency, and they need to get to a referral center that can start IV fluids right away, because if you get too dehydrated, then you start problems with your kidneys not functioning, and it's much harder to regain the ground that you've lost versus maintaining it. They can also suffer from laminitis. They can have clots form in their jugular veins where the IV catheters are, and so they can get really sick if you don't get on top of it right away. Clostridium difficile is one reason. Salmonella is another. If we suspect it at all, being salmonella, we'll put these horses in strict isolation. They're not even allowed into the main hospital. They have their own room. They have their own stall cleaning stuff. They have their own stethoscope, their own thermometer. Everything is, their own. And in this area, we do need to worry about Potomac horse fever. That's from July to November. And the vaccine it won't prevent it. It will help it from being less severe, but it will not prevent Potomac horse fever. So it's important to remember that even though they can be vaccinated for it, it may not prevent the disease. Small intestinal problems that we take to surgery are going to be the lipomas that we talked about. They have this black intestine that we see at surgery. On ultrasound prior, it's going to be thickened small intestine, has a little donut-shaped small intestine here on ultrasound, and they're going to have that red cloudy fluid. These horses are going to be pretty darn painful. Once we resect that portion of the intestine and reconnect the healthy ends, they usually do quite well, with the exception of a few horses can develop problems with starting to move the intestine again. You take out a section, they have to relearn how to move that intestine again, and sometimes it takes several days for that to happen. And if they develop any scar tissue, these are the horses that may potentially become chronic colicers for you, because of the scar tissue that can glue things into abnormal position. So if they're going to have about a 30% chance of having scar tissue in the abdomen. Not all of those horses will have problems with it, but it is a higher risk procedure than some of the others. With these strangulating obstructions, all we see is these big black circles on ultrasound. And they're going to be typically lipomas, which are just little fatty tumors that form on a stalk and wrap around a segment of intestine. But it can also be an epiploic foramen entrapment, and that's preventable in a lot of cases. All right, epiploic foramen is going to be up by the liver and the pancreas, and it's a natural opening in the abdomen that the intestine can get trapped through. What things can't we fix? There's a few, and we never want to find these, but every now and then we will. If they have ruptured their stomach or if they've ruptured their intestine after being twisted, we cannot fix that. It's just massive infection, and there's nothing that we can do for those horses, and they have to be humanely euthanized on, just grounds of kindness, because there's nothing else that can be done. We can only take out so much intestine. Of that 60 to 70 feet of small intestine, we can only take out, we can take out up to 30 feet, but that's pushing the ability of that horse to absorb nutrition and be able to maintain weight and good quality of life afterwards. The other problem is that intestine that's affected by whatever problem it is may be in that 25% of the abdomen that we can't get to. If it's very deep in the abdomen at the base of the cecum or very close to the stomach, we can feel it, but we can't see it. And we have to be able to actually pull it up out of the abdomen to fix it. So if it's in that 25%, unfortunately, we're not going to be able to do it. But that's pretty rare, actually. Things you can do to prevent it is good, solid deworming. Get with your veterinarian on the farm. Get a good rotational deworming program. Make sure you're doing fecals, and things like that to really make sure that you're ahead of it, especially in babies. A good deworming protocol that starts right away once they're born is important. Tapeworms, though, they don't show up on fecal floats. So you have to deworm twice a year for tapeworms, just automatically. Even if you have a negative fecal for all the other kinds of parasites, you still have to deworm with a product called praziquantel, which is in no particular order. There's Quest Plus, there's Imectrin Gold, there's Equimax. Any of those products, and I'm not recommending one over the other, I'm just saying those are the types of products that have the praziquantel in it, and you'll need to use something like that twice a year. You can avoid sand. We also briefly talked about this a bit, making sure you feed up off the ground, feeding on mats, and if you do live in a sandy area, administration of sand clear per label directions will help minimize the chances of sand accumulating and causing problems for you. The biggest thing, and some of it just goes back to common sense, you don't want to change anything too drastically. If you're, find a good feeding program that works and make sure that any changes that you make very, very slowly. Grain in particular, it's not so much changing your types of hay, unless you're going from grass to alfalfa, but like one batch of grass hay to another isn't such a big deal, but changing types of grain and things like that, you'd want to do really, really slowly over about a week to 10 days. The more that they can eat, the better. Horses are meant to walk around all day and eat and move and eat and move and eat. And the more that we can mimic that, the better. We take horses and put them in a stall and feed them twice a day. That's not how their intestinal tract was designed to work. So if you can mimic the natural feeding style of a horse by having them munch on something all the time, you'll minimize problems. Water availability becomes an issue in the winter. Heated buckets I know are a hassle, but they're really important. You have to make sure they're drinking water. They'll get impacted, they'll get dehydrated, and we actually see more impactions in the wintertime versus summer because they don't have a stimulus to drink in the wintertime like they do in the summer when it's hot. Knowing how much your horse has been drinking is important. That's something that we're always going to be asking on a colic exam is, did he drink anything during the day or overnight? Now, I recognize that automatic waterers are needed and handy and all that sort of thing, but sometimes, a horse can go quite a long time without drinking and you'll never know it because he's on an automatic waterer. We talked a little bit about winter, and this last winter I know was just an awful thing for everybody. Water buckets broke and froze even though it was doing our best. It's just one of those things that kind of have to battle through. And just basic dental care. If they can't chew their food properly, can't masticate their hay, they are at more risk for impactions and things like that. So making sure that you get their teeth at least evaluated on a yearly basis, if not every 6 months if they're older, is going to go a long way in preventing some issues. Cribbing, though, is so easy to prevent, and it does increase your risk of colic significantly. They can have ulcers, they can have large colon gas, and they can have epiploic foramen entrapments, and their risk goes way up to having an epiploic entrapment if they're a cribber. It's a known fact, and it's so easy to prevent. A, it's destructive, B, it's annoying, and C, it's dangerous for your horse to allow them to crib. And we'll ask that, we'll double check, you're checking the teeth when they come in. Hey, is your horse a cribber? Well, no, but he chews on the wood a lot. Yeah, unfortunately, your horse is cribbing. And, now that tells us that we need to rule out a few things specifically because he's a cribber. Prevention is sometimes not pretty. If the cribbing collars don't work, you know, there's so many of them out there, you may have to put a cribbing basket on there. They don't look good. Nobody wants to see their horse walking around with a big basket on their face all of the time. But really, you have to get past that appearance factor because it truly does, you know, in some instances save their life. If you can stop them from cribbing, especially if you can't afford to take them to colic surgery, that cribbing muzzle's not that expensive. And I wish more people would stop their horses from cribbing because, you know, they say they don't mind them chewing on the barn and things like that. It's not from a barn's perspective that I'm worried. I mean, your horse truly would benefit if they can stop cribbing. You know, they will be at less risk of ulcers, less risk of gas colic, and, you know, that surgical colic risk goes way down if you can make them stop. And that's my little soapbox for that, and I'm done. You can't prevent everything. You can't prevent torsions or displacements. Sometimes epiploic foramens you can't prevent, you know, because they can happen in horses that don't crib, but the cribbers, you know, you can prevent it. You cannot prevent lipomas. It's going to be in older horses, but it's not related to food, management. It's just something that the horse gets, and there's really nothing you can do to prevent them. You're not going to know that they're there until they actually are causing that surgical problem. In feeding and making sure you're away from sand, you can help minimize enteral formation, but again, if they eat a little bit of twine string or some little bit of foreign something they ought not to, you know, that could be an instance, so you can't entirely prevent them. At home, if you're comfortable with the physical exam on your horse, that'll give you a heads up in warning your vet and helping them determine what's going on and how quickly they need to get there. And we already talked about what we can or cannot prevent. And that's something that people ask, well, what if I had done this or what if I had done that? These things you just, because of how the horse's anatomy is put together, you just can't prevent it. The lipomas you can't prevent. And, you know, your good management, making sure your feed changes slowly, you know, good deworming protocols and things like that will go a long ways in preventing some types of colics. And the sooner you can get a vet to look at that horse, the better. If your vet can't come out, wherever your closest surgical facility is, you know, load them up and take them. Call them and tell them you're coming so we're prepared, but load them up and take them. If you are worried, you know, call ahead and say, hey, we've got a colicky horse, my vet can't get out there for another hour, I can be to you in 45 minutes. Just go, because you'll rest a whole lot easier in the long run. And with that, I'd be happy to answer any questions. Yes, ma'am.
Let's get back to ulcers a minute.
Okay.
Antibiotics help.
Antibiotics help?
Probiotics.
Probiotics. There's no official documentation that probiotics will help an ulcer. They're certainly not going to hurt.
Okay, I'm suspecting, I don't know, I haven't had my horse skip, but I have one that's kind of an overachiever that worries about things.
Okay.
He's had like a personality change, he's kind of biting.
Yeah.
When you cinch him off.
Yeah, it sounds like he needs to have a gastroscopy. Sometimes the probiotics will help colonic ulcers more than they will help gastric ulcers. And you can't scope them to check their colon. You can check their stomach, but you can't scope them to check their colon. So he really would benefit from the scope. Yes. Yep. She was next.
We took our gelding to replace 2.5 years ago for surgery.
Okay.
The distended large intestine. He's great now, but
Good.
at the time, Dr. Jackson said to give him the Equine supplement,
Right.
probiotic. And now there's all these new things on the market.
Sure.
Is that still what you recommend as the best one? I want to make sure he's having the best one.
There's a lot. Her question was, what is the best probiotic for large colon gas and things like that? There's a lot of them out there. Equibios is one of them that we've had good luck with. I don't know that there's one that's out there that's any better or worse. If you know your horse is doing well on the probiotic that you have now, if it isn't broke, don't fix it. You know, we'll just keep very consistent and things like that. So, she was next.
I would think in Northeast Ohio the biggest cause of colic would be spring grass, which you didn't really hit on.
We don't see that very often. The question was, you know, spring grass and, you know, things like that causing them to colic. We don't see that very often. Most people are really good about the slow introduction, and things like that. We really don't see a lot of colic secondary to, grass. Horses that are out on pasture all the time, as the grass is starting to grow, they're, gradually starting to eat it, so they get exposed to it as it grows up. The horses that are stall confined that just have intermittent turnouts, some of them will be a little bit, gassy, but we really see that very, very rarely, at least in our hospital. Now, a lot of those things that are coming in are stuff that can't be handled on the farm or doesn't respond. So certainly some of the referring vets in the area, may be seeing more of those, but really we get very few calls about them as well. Most people are really good about the gradual introduction to grass, and it keeps that to a minimum. So, yeah.
This question is sort of water under the bridge, but I had a horse that had displacement surgery when he was a 2-year-old.
Yes.
He was fine for 4 years, and then in February he displayed severe colic symptoms, and unfortunately we never did get him to the clinic.
Okay.
He had to be euthanized.
Oh,
but
dear.
having a repeat surgery, what are the chances? I mean, I know you can't really answer the question, but is the chances of prognosis decreased if the horse had previously had surgery?
Question is, if a horse needs a second colic surgery, what is the prognosis for that horse? It depends on the reason for the second colic surgery, okay? And typically, if it's a different reason than the original colic surgery, which oftentimes it is, the prognosis just goes with whatever problem it's having at that time. If it is the same problem that the horse had the original colic surgery for, say, for example, a large colon displacement, and they're having a second surgery within a year, that horse is going to do it again. But if your horse had gone 4 years, the chances of him having it a third time would have been, really very low. But it just, if he had had something different, though, we wouldn't know until we got in there. The biggest thing with a second colic surgery is the incision, okay? The abdomen only heals to about 80% strength the first time. And, that's fine, it looks good and it's firm and solid, but the second time you go through, you're going through a little bit weakened tissue. And so they can have an increased risk of hernia formation, which is a little keel or outpouching of the skin there. If it's very, very close to the first surgery, say within 6 weeks or so, hopefully not, they're at a little bit increased risk for incisional infection. So those are the things that are more concerning with the second surgery versus, the actual cause of that colic episode themselves, unless you're looking at a large colon displacement that happens within a year of the first one, then those horses are gonna do it again. So, yes, sir.
You emphasize keeping away from sand.
Yes.
I was wondering, why do they have products on the shelf in the digestion area that says that it's actually sand on the shelf in there and it's for good digestion? What is that?
I'm not actually familiar with any of the question was, keeping away from sand, and he's seen some products on the shelves that have sand in them. I'm not familiar with what those products might be to you be giving them for it. I wouldn't.
I never give it to, but I noticed on there, when I was checking probiotics, it's in the same area.
Yeah, I wouldn't recommend giving anything that has sand on the label. I don't know why they would. I don't know what they are, but I would be cautious. Yes, Rhonda.
I've heard that somebody promoting Purina Altium as particularly good for horses that have colic ulcers.
Sure.
Is that true, or is that any better than, say, senior?
Sure. The question was for horses that have ulcer problems, is Purina Altium a good food, good diet for them? Is it the best thing for them? What's the deal there? I'm not a nutritionist, however, we do have good luck with giving horses with ulcers Altium because it's high in fat. So it's higher in fat than Equine Senior, but that doesn't necessarily mean that you can't give them another high-fat dietary grain in place of Altium. So that's kind of where they're coming from with that recommendation, is increasing the amount of fat in that horse's diet using the Altium to do it. Some people don't that might be a little not wanting to feed so much grain, you can accomplish the same thing with a cup of vegetable oil twice a day, type of thing. You know, when it comes down to economics, you know, certainly adding, if you have them on a pelleted diet, just say a 12% pellet, and then add the fat back with vegetable oil. I honestly go to Walmart and find the generic vegetable oil in a 5-gallon jug. Start with a 1/4 cup twice a day, work them up to a cup twice a day slowly so you don't give them diarrhea. You can accomplish the same thing. Other people choose to do it with grain and Purina, Altium, and things like that, but you can do the same thing with just putting vegetable oil on their diet.
Well, he's getting Altium right now.
Okay.
I just didn't know whether it was worth being invested or not.
If he's doing well and you notice a good improvement on it, again, I wouldn't change it unless you absolutely have to. Ma'am, you had a question.
Yeah, and what's the logic with the alfalfa versus typically or Lactate for ulcers?
I'm not sure they know exactly all of the ins and outs of it. I believe it has something to do with the calcium content in there and things like that, helping the pH of the stomach stabilize a little bit. But we do try and add, you know, some alfalfa to these horses' diets, even if it's alfalfa cubes, alfalfa pellets, something along those lines to just help buffer some things.
So one of the benefits of alfalfa is alfalfa contains a higher calcium level. I guess I should introduce myself. I'm the Ulcer Guard guy. My name is Ryan. I work for Mariel. But I also, my master's is in cattle nutrition. So I do a lot of work with nutrition as well. Alfalfa contains a higher calcium. Calcium is our first buffer. When we get a bellyache, usually we're going to pop a Tums, and Tums is calcium. Calcium will buffer buffer stomach pH. And if we buffer stomach pH, that's our first step in decreasing the risk for ulcers. So usually we recommend in horses that are prone to ulcers. Also, calcium and alfalfa tends to have a little bit higher energy. So we're looking at horses that are performance horses, and we're trying to get them a high energy diet, yet not feed them loads and loads of molasses or rapidly fermentable carbs that are going to decrease the pH. So alfalfa really works nicely because it provides us more energy and a buffer. So that's why the logic is there. A lot of different solutions to a very, very complex problem.
On horses that get the lipomas, do you see any dermal lipomas? Or
No. Now, the question is, the horses that get the strangulating lipomas, do you see any corresponding like little fatty lipomas like dogs and cats will get underneath their skin? We don't see that in horses. Well, they can get them, but they're completely unrelated. They're actually very uncommon in a horse compared to a dog or, you know, small animals. And they're not, even if we find one underneath the skin, we're not going to be worried that they have one internally. They're not related in any way.